Death is inevitable. Though we live in a particularly death-denying society, death continues to be a normal part of the life cycle. Everyone is born and everyone eventually dies. The goal of hospice care are to provide an alternative to intensive end-of-life care in the hospital or home setting, and to provide focus on the quality of life and symptom management instead of treating the actual disease, and to provide psychological support during the natural dying process. The reason I chose this topic is due to my personal experience with the decisions around hospice and end-of-life care when my mom was diagnosed with stage 4 lung cancer a few years ago and then was eventually referred to hospice. The focus of the social problem that I chose to specifically talk about today is that professionals that work with hospice and palliative care patients do not receive enough training in this area to appropriately provide their patients with enough information about their options. Patients do not receive adequate information to make an informed decision about options for long-term care available across the continuum of healthcare and also regarding residential care options. Clinicians who are responsible for the treatment of patients at the end of life commonly lack adequate training to help guide end-of-life decisions and to deliver bad news to patients and families. I experienced this firsthand when my mom was given her diagnosis. There was a lot of hope that was provided without providing the bad stuff that came along with a stage 4 cancer diagnosis. Information that I learned from the National Institute of Health is that many physicians, after spending 7 to 14 years with intensive training and heavily focused on science and technology, feel uncomfortable when directly addressing issues, particularly those concerning spiritual and emotional needs faced by patients and families at the end of life. Due to the lack of training and education of professionals, patients do not receive adequate information to make informed decisions about their options of end-of-life care, palliative care, whether it be hospice or legal options like advance directives or living wills. With looking at the statistics, there are one palliative care physician for every 1,200 people diagnosed with chronic illnesses, in comparison to one cardiologist per every 71 patients that are experiencing heart attacks, or one oncologist for every 141 people diagnosed with cancer. The management of end-of-life care and the process of engaging in difficult conversations are topics that are frequently neglected in the medical profession, and physicians need to be educated in how to communicate with patients in giving them this devastating news, whether choosing to continue treatment options or participating in chemo versus going home with hospice care and just treating your symptoms and working towards and preparing that patient for death. Professionals that work with end-of-life patients also need to be equipped and being educated about the services that are out there for patients. A lot of the patients that they're working with have diminished capacities that have to make decisions based on how they're going to end their life. So professionals need to be able to refer them to the appropriate resources, and they're only going to get that through education and training. There are several correlates in regards to the lack of education and training that professionals are receiving in regards to hospice and end-of-life care. Clinicians have to have education and training and be able to face their own discomfort in having conversations and discussions with their patients and their families about dealing with death and making those end-of-life decisions. They also receive poor compensation for the time that they are spent in discussing these issues with their patients. In regards to nationally, there is going to be a huge financial issue in regards to end-of-life and hospice care. The demographics of the United States demands a federal focus on policy and support of older adults. The Trump administration and Congress are facing a long-term shift in the composition of our country's population. With America's baby boomer generation, every day 100,000 boomers turn 65, or nearly 10 million in the next 3 years. By the year 2030, 73 million or 1 in 5 people in America will be 65 and older. It is critical for lawmakers at all levels of government to recognize that these demographics are going to have a fiscal impact on the national budget. So education and training in this area is going to be crucial to providers. And with patients being informed for their eligibility for hospice is also an issue. Physicians have to be informed about this process because it does take a physician to refer a patient for hospice. A patient has to be certified by a physician that they have less than 6 months to live in order to qualify for hospice services. People facing end-of-life decisions are not equipped to make these decisions because they are not being informed by people who have education and training in regards to what is out there for them. The Palliative Care Act defines palliative care as a specialized medical care for people with serious illness with a focus on relieving suffering and improving the quality of life. No specific therapy is excluded, and that the individual's needs must be continually addressed and assessed, and all treatment options are explored. Whereas hospice, if a person is referred there, they are agreeing that they are not going to be receiving any treatment and they are just going to be made comfortable until the time of their death. So for a patient to be able to make that type of decision, their professionals, their team has to be well informed on what is out there for them. Patients have to be able to understand what services are available to them in order to make those informed decisions, whether it's hospice, palliative care, are physicians or other professionals equipped to identify counseling services, family counseling, end-of-life directives, spiritual counseling, insurance and financial help. Patients that are preparing for end of life are not informed or educated about what their options are or how to navigate that system. From my personal experience with my mom, we were told that hospice was an option for her, but that treatment would help and it would extend her life. So she was participating in chemotherapy weekly, which I was actively participating in with her, going to all of those appointments and having communications with her doctors. And we were very ill-informed about the seriousness that hospice should be an option now. She was dying and we really did not have any idea. In response to this social issue, the Palliative Care and Hospice Education and Training Act was enacted. This put in place to amend the Public Health Service Act to increase the number of faculty in palliative care, specifically with educational programs. This is also known as H.R. 1676, which was passed by the House in late 2018. Specifically, this act requires the Department of Health and Human Services to provide support for palliative care and hospice education centers. It must improve the training for health professionals in the palliative care arena. It establishes traineeships for individuals preparing for advanced nursing degrees, social work degrees, and physicians who plan to teach palliative care medicine. It also provides academic awards for individuals to promote their career development. This act also supports entities that operate palliative care and hospice education centers. It also requires research and a quality approach to the education and awareness campaign to inform physicians, families, and health professionals about benefits of palliative care. It also expands the research for palliative care, and funds are available for that. There are also grants eligible under Section 832 of the Palliative Care Act. And these grants can be used for implementation and programs of entities to train and educate individuals who are providing interprofessional team-based palliative care in health-related educational, hospital, hospice, and long-term care settings. There are a lot of benefits to this act. I know my family would have benefited from an interdisciplinary team that could wrap around our family in better understanding the options in regards to a chronic disease that will lead to death. In conclusion, the National Association of Social Workers have standards for palliative and end-of-life care, which include continuing education. Social workers working in end-of-life care should be able to demonstrate a working knowledge of the theoretical and biopsychosocial factors that in regards to end-of-life care, and possess knowledge about navigating the medical and social systems that present barriers to clients, and understand the physical and multidimensional states of the dying process. Clinicians should be comfortable engaging patients around their concerns about death and referring patients to social workers, chaplains, or psychologists. Clinicians must keep in mind that the difficulties a patient faces when in the process, as well as their own professional and personal obstacles to performing this type of work to the best of their ability. Hospice is an amazing service, and it is very important for professionals to recognize when it is time to have that conversation with a patient and their family so that the patient can be involved in that decision-making process. My experience with hospice was wonderful, even though it was only for 2 days. It was still yet an amazing experience, and they provided support that was truly needed. Thank you for watching.